afternoon and welcome. Thank you for joining us today for our webinar. My name is Meg Beyer and I am the Assistant Director of Strategic Operations here at the McSilver Institute. I'm really happy to be joining as one of the TTAC partners. And I'm really excited to be here today for our webinar on psychiatric medications in young children. Lots of questions and some answers. So I'm going to be joined by our colleague, Dr. Rebecca Weis, and Evelyn Blank shortly, who will do a little intro on our TTAC project. But before we dive in, just a few logistics about today's webinar. So as we've done in the past, this webinar is going to be recorded, and the recording of this webinar, along with the accompanying slides, will be posted to the TTAC website. So give us a few days. We'll upload the recording and the slides shortly to the TTAC website if you want to share those with colleagues later on. We are going to be taking questions throughout the webinar and would request that you send in your questions via the chat box functionality, which can be found on the right side of your screen. We set aside time at the end, but if you want to chat in questions throughout the entire webinar, we encourage you to do so. With that, I want to thank you all for joining us, and I'm going to hand it over to Evelyn to get us started and to see if we could advance to the next slide.
Thank you so much, Meg. My name is Evelyn Blank, and I'm the director of the New York City Training and Technical Assistance Center, and we are really thrilled to have so many people join us today. The New York City Training and Technical Assistance Center, affectionately called TTAC, is funded through Thrive New York City, and it's under the New York City Department of Health and Mental Hygiene. And it is a partnership between two agencies, my agency, the New York Center for Child Development, and the McSilver Institute on Poverty, Policy, and Research. And just briefly, New York Center for Child Development has been a major provider of early childhood mental health services in New York. And we have expertise not only in informing policy, but also supporting people through both training and direct practice. And we are very privileged to be partnering with the McSilver Institute for Poverty, Policy, and Research, which houses the Community Managed Care Technical Assistance Center and provides ongoing technical assistance and support with a focus on business sustainability. The charge of the network is really to build the capacity and competencies of professionals, both in mental health and other child-serving systems, and also to identify and address social emotional needs of young children and their families across New York City. So before I introduce our presenter, I just want to direct you to the next slide, which really gives you a link to our website. And I would like to encourage people to go there to find out about additional resources and find out what opportunities are there. These webinars are all archived, and you can go in and get a historical history of all of the archived webinars. So it is now my privilege to introduce Dr. Rebecca Weis, who is a colleague and friend here and is currently the Director and Chief of Service for Child and Adolescent Psychiatry at Bellevue Hospital Center. She had recently been working with Thrive New York City as the Medical Director and Consulting Psychiatrist in Early Childhood Mental Health for the Mental Health Service Corps. She currently maintains a faculty appointment at NYU as Clinical Assistant Professor and Associate Director of the NYU Bellevue Public Psychiatry Fellowship. She also collaborates with the Women's Mental Health Team at Bellevue and provides psychiatric treatment to both pregnant and parenting women and adolescents. She participates in teaching at the undergraduate as well as postgraduate levels in child psychiatry and public psychiatry fellowship programs. She is a member of various professional societies and work groups at New York and national level, including those focused specifically on early childhood mental health. So thank you, Rebecca. We look forward to a very interesting, informative webinar.
Thank you so much, Evelyn. I appreciate that lovely introduction, and I'm so glad to be able to be here today with everyone. I was just going to make sure that you can hear me. I assume you can, or you would let me know.
Yep, we can hear you.
Okay. And then I wanted to just, as I'm going into the slides, make sure everyone's aware that I have quite a bit of material in the slides, and I want to make sure that we have some time for questions before we have to finish up at 2. So I'm going to fly through some of the slides, and they have more content on them than I'll be able to, touch on every detail, but the slides will be posted and the webinar as well, as was mentioned, so you'll have a chance to go back and review more detail if that's helpful to you. So as we talked about already, the topic today is psychiatric medications in young children. And I framed it with the title, Lots of Questions and Some Answers, because there really are, we're working with less information about a lot of this than we would typically like to have. And I'll talk about that a little bit as we go through the presentation. But there are some things that we do really know and that can be really helpful. So as we're going through, I wanted to just bring your awareness. These are the learning objectives. So we're going to talk about how common is psychiatric medication use in young children, just to help you be aware about that. And then how do mental health professionals approach treatment decisions with young children, including for medication. And then finally, we'll go through some basic categories of psychiatric medications and talk a little bit about what might be important to know about each of these. So starting off with how common. So this first graphic is actually not about medication at all. This is about diagnoses and kind of prevalence data for different age groups. So on this slide, you see comparisons for 3 different age groups. That includes preschoolers, which in this study that, in this article that pulled a lot of information together from some different studies that had been done, they have 3 categories: preschoolers, who are kids age 2 to 5, children aged 5 to 17, and adults. And so the darkest bar is the preschoolers. And what you'll see is that children and adults have a higher prevalence of psychiatric disorders overall, but preschoolers do have mental health issues as well. And so based on this research that is quite solid, you can see kind of the prevalence of different things. Serious emotional disturbance, although that's used as a classification for IEPs, is not technically a diagnosis, but ADHD, oppositional defiant disorder, depression, anxiety disorders, you can see all of those represented here. This is not an exhaustive list of diagnoses, but it's many of the more common ones. And one of the things that's interesting is just noticing how things kind of shift over time. So you'll see, for instance, that young children have a pretty significant amount of anxiety disorders, and where it says any anxiety disorder, but you'll see that generalized anxiety disorder, that's GAD, and social anxiety or separation anxiety disorder, which is SAD, are more prevalent in preschoolers, and then over time become less prevalent, whereas social phobia and specific phobias, by the time we get to adults, are the more prevalent anxiety disorders. Sometimes the presentation of symptoms morphs over time, but oftentimes kids who are very anxious at a very young age will also continue to struggle with some anxiety, and it may just present differently over time. So that's just an interesting point, and it gives you some idea that about 15 to 20% of preschoolers may at some point during their preschool years struggle with either a transient or more consistent mental health issue. And then in terms of medications, I'm going to tell you about 3 studies that have really tried to look at this in the United States. And so this first one is a national study that looked at the years 1994 through 2009. So I've pulled out the more recent data because it's closer to where we are now. So in 2006 to 2009, 1% of children in the sample that they looked at was on a psychotropic medication. And then they found some differences in this next group section where it says some disparities. Boys were more likely to be on medications than girls. The kids who were older in the group, so the 4 and 5-year-olds, were more likely to be on medicine than the 2 to 3-year-olds. White children actually tended to be more likely to be on medication, and those lacking private insurance, which is basically backwards speak for those who are on Medicaid. So that just kind of gives you like some broad strokes views of things. And what's interesting is some of the other studies found some very similar characteristics about who was more likely to be given medications. ADHD was the most common diagnosis, and stimulants were the most common medication used. We'll talk more about both of those things later in the talk. And that there was also higher rates of prescriptions for those who had more than one diagnosis at a time. So some kids have ADHD symptoms and also have some mood symptoms, and they are more likely. They present often with more complex symptoms, and so medications may be more considered. This next study, just very quickly, also looked at a nationally representative sample. It looked at kids from age 2 all the way up to age 18. And what's nice about it is we have data from 2014, so that's getting even closer to the current state. And what they found in 2014 was that in age 2 to 4, about 2.63% of kids in the sample they looked at were taking a psychiatric medication. That it actually decreased somewhat from 3.08% in 2004. You might be asking right now, why is it 3% on this slide or 2.5% versus this other study said 1%? There are always questions about how one collects data, and so it's rare that things would be completely consistent. This group looked at kids who had private insurance and Medicaid. This study looked at only Medicare and Medicaid. So there's some differences in the sample. And so this goes along with what I said about, from that previous study, the kids who lacked private insurance had a higher rate of medication. And so you see that here. And then this last one is only in Ohio. So I include it mostly because it just showed some similar things, and they also looked at what are the most common medications used. So about 1 in 10 children in their study had a mental health diagnosis, and again, they were looking at insurance claim data, which is how a lot of these kind of big epidemiologic studies are done. There's some other ways too, but and their overall rate of prescriptions was about 1.9%, and then you see the most common medications. Again, we're going to go through these different types of medications later in the presentation, so I'm not going to get too deep into that right now, but you see there's kind of a spread across different types of medications. They found similar things about who was more likely to be taking medication. They also found that those living in poverty and living in an urban area were more likely to be prescribed medication. Being in an urban area might mean more access to mental health services, so that might explain part of that. Unfortunately, we all know adversities contribute to mental health diagnoses and are risk factors in all age groups, so that's not really a surprise that that would also be the case for young children. And we'll actually come back to this study just to comment on one other thing later in the presentation. So hopefully that gives you just a broad strokes idea. We're actually talking about quite a small percentage of children who are prescribed medication in their early childhood years. So, so this is, significant, but, relatively small. And sometimes people worry that there's been an increasing rate of use of medications with young children, but actually if you look at those numbers and think through them, it's been pretty consistent, somewhere around 2 to 2.5%. If you average different things together. So that's probably about the amount of kids you would expect to see on some medication. So now we're going to turn to kind of thinking through how mental health professionals approach treatment decisions. And so I've made this diagram that really kind of walks one through the different parts of things. And we always start with a really thorough assessment that leads to some diagnosis, if there is one. And if there is a diagnosis and enough impairment, then we will think about treatment options, really have to think through risks and benefits of any treatment, whether it's medication or another type of treatment, and come up with a treatment plan. And then I make this diagram completely circular because even as you get into a treatment plan, you should always be reassessing and then going around this circle in your mind again and again to make sure that you haven't missed anything, and also, in case things change over time, that you stay on top of those changes. So I'm going to walk you through a little bit more about assessment and diagnosis. So, many people on the webinar may already be aware, but just in case, this is a diagram of the criteria for attention deficit hyperactivity disorder. And, obviously, in mental health, we don't have a lot of lab tests or imaging tests that we can really use to get down to the nitty-gritty of what's going on. So we have to do a lot of our work by talking with people, observing symptoms, and matching those up to what makes the most sense in terms of a specific diagnosis. And so I put this up here because as we already covered, ADHD was probably the most prevalent diagnosis that has been shown in those studies in young children. And at least amongst those who are taking medication. And, these are the criteria that are used for really any age kid based on the DSM, Diagnostic and Statistical Manual. But I wanted to contrast that quickly to the DC 0 to 5, which many of you may know is the kind of specialized version of diagnostic criteria for young children, and it focuses on incorporating developmental issues that may affect how symptoms present in young children. So I give you, in contrast, a diagnosis that they have included in DC 0 to 5 for younger kids. So ADHD as a diagnosis has really been kind of closely looked at with a lot of scrutiny about, can you diagnose this in young kids? And down to around age 3, people have gotten pretty good at making a diagnosis that will, with symptoms that continue over some time, because that's what you want to avoid is diagnosing a kid who's struggling with something that's really a different problem, and they look hyperactive in the moment, but really it's because of something else that's going on. So you have to be very careful in making diagnoses. Part of what also is recognized is that, ADHD doesn't just start necessarily at age 3, but we may not be able to really diagnose it younger than that because there's so much hyperactivity or just high levels of activity in kids under age 3. So DC 0 to 5 has tried to put together a description of symptoms of what you might see in toddlerhood if a child is kind of on the path to a ADHD diagnosis. They really stress the importance of looking at other possible explanations, though. The reason they've done this is to show, potential that you could potentially get children authorized for getting certain types of services because they've got clinically impairing symptoms, even though they don't meet full criteria yet or aren't very, completely clearly diagnosable with ADHD yet. Concerns are raised, though, as well, because we don't want to pathologize typical behavior patterns. And as we'll go over later in the presentation, really, the youngest we're going to use medications for ADHD is usually around age 3. So this diagnosis shouldn't so much be the basis for our medication exposure. And they put certain safeguards into how they word things. So, the activity level and the impulsivity really has to be excessive compared to other developmentally and culturally expected norms. So you have to really think about the child's developmental level, what all the other 2-year-olds are like, and what their culture is like, and what they expect from children, because children conform to the expectations oftentimes, and it must be causing some impairment. So that's just to kind of say, like, this is a really careful thought process that, often takes multiple sessions of getting information from the parents, from the school, from other environments where the child might be, and also observing the child themselves before coming to any kind of diagnosis in young kids. If we do have a diagnosis, then we'll move it on in this diagram, as I said, to treatment options and kind of think about what are our options here. Our general approach to treatment in young kids, you'll see in very large letters on here, is that therapy or psychosocial interventions should really be first choice. The thing is, we have a lot more evidence for the efficacy of psychotherapies and other psychosocial interventions for young kids. That's been pretty decently researched, and there's ongoing great research looking at different treatment modalities and what's most helpful. We'd have less data in a lot of ways about medications. So, we want to start with what we understand to be helpful, and then really think about medications for those kids who are continuing to have impairment despite those psychosocial interventions, or who also, are occasionally there will be a kid who, like, the problems are kind of so bad at this very moment that you want to make sure you give them every possibility of being successful as quickly as possible. So occasionally you might think about medications kind of simultaneous with starting other treatments, but you really want to make sure that you get kids access to these other interventions. You also want to really make sure that you're addressing parental issues. So, some parents really benefit from some parent management training or other coaching, and some parents who themselves may be struggling with a medical or mental health issue benefit from getting treatment for that. And then that secondarily helps the child. And as I already mentioned, when meds are indicated, we really want to be thinking about how is that also being combined with other treatments. And just continuing on that theme about thinking about medications for young kids, I say this about not only psychiatric medications, but many, many types of medications. Like there's just a lot less research. There's a lot of complications with trying to include young children in research studies. They don't have any understanding themselves of of consent even, and whether or not they want to have this option versus that option, because they're still getting to the point that they understand cause and effect, and getting to the point that they would even understand, a problem that they're having compared to a problem that another child is not having. So this really limits and will continue to limit our evidence base in a lot of ways. That doesn't mean that we can't understand things, but it's just always going to be a bit of a challenging area. And some of you are probably aware, that the Food and Drug Administration, the FDA, is the entity that approves medications for use in the United States. And there are actually very few medications that have been FDA approved for children, both non-psychiatric and psychiatric. So a lot of times what we're doing as doctors is thinking about, off-label prescribing, meaning, like things may be good for other indications besides what the FDA initially approved it for. And that's often understood through case reports and kind of collective experience amongst a field. And we don't have much long-term data available either for, are there any long-term effects of certain medications? So that's something people are trying to do to track kids over some more time. I'll tell you about some of the things that people have been able to follow up. But these are our limitations. I want to be transparent about that. Just so you have awareness, I said few medications are FDA approved below age 6. This is the total number of medications that are approved for psychiatry use, at least under age 6. And most of them are from a long time ago. So haloperidol and prochlorperazine are older medications that we would very rarely, if ever, use in young kids at this point because they're just out of date in a lot of ways. We do use haloperidol quite a bit for older kids and for adults. It's still a good medicine, but sometimes the way that the FDA looked at things in the past is not kind of at the same level of scrutiny that it's looked at today. So I just wanted you to see that these are the ones that are approved and understand about that, but I'm not going to go into more detail there. And okay, so kind of gave you a little bit of information about what the treatment options would be, and it really kind of breaks down into some type of therapy or psychosocial or parenting intervention, and then also the option of medications. And as we try to pick through those decisions, we're going to weigh risks and benefits of different options. So this is from the American Academy of Child and Adolescent Psychiatry, and in 2007 they had put out guidance about psychotropic medication in preschoolers, and they really reviewed the evidence that is available and came up with what they thought would make sense. So they said really only recommend a trial of medication after a trial of evidence-based psychosocial treatment has failed or is inaccessible. In New York, we have, at least a reasonable number of options nowadays, and the TTAC has helped expand the options. So there are more clinicians out in mental health clinics and such that are trained in psychosocial treatment options for young children and their families. So that's great. We really can usually access that for them. In places in upstate New York and even in other parts of the country, sometimes those options are not so accessible. So sometimes people might go to thinking about medication a little bit sooner if they happen to have access to that, but not to the other stuff. And then also in instances of moderate to severe symptoms where there is some functional impairment and a high risk of injury to self, others, or worsening family dysfunction. So really, don't treat mild problems with medications. only when it seems to be like the most important thing at this moment. And then they, put together some algorithms that are based on available evidence for specific disorders, and they encourage some of the things that I already mentioned about a thorough diagnostic assessment, and really looking at parental wellness, because that might be impacting on childhood symptoms. And then the final thing is, if you do start a medication, think about trying it for a short period of time, monitoring that consistently, and really tracking, like, is it successful? And also, is there a point when maybe we can discontinue the medication? Because the worst thing is it's kind of if medication is just started at a certain point and never reevaluated. So you want to set up ahead of time a plan, like, we're going to reevaluate this in 1 month, again in 2 months. By the time we get to 6 months, if the kid has stayed on it for that time period, we're really going to think about, do we need to continue it or not? So having that as part of the thinking from the beginning. This is a little bit more general about risk-benefit, and then I'm also throwing in risk-risk as a concept. So with any treatment decision, what mental health professionals and other professionals in the medical field usually are thinking through is, is there a risk to this treatment? Is there a benefit to this treatment? And how do those weigh against each other? And then the other thing I'm encouraging you to think about as well is, like, what is the risk of the untreated problem? So if we think about aspirin, which, everyone's taken an aspirin, but you can get side effects. You can get upset stomach or increased risk for bleeding, but you get a lot of benefit, decreased pain and inflammation. And the risk of the untreated problem is continued pain and inflammation. Or, sometimes people are taking aspirin because of cardiovascular disease, and then it may, even have kind of a higher benefit than we would think about for the usual headache or sprained ankle. And so I've just put here also, kind of risk benefits and risk of untreated problem for a medication we'll talk about, dexmethylphenidate, and for parent management training. And I've just noticed a little mistake I made. That should have just said methylphenidate. So I will send some corrected slides so those can be sent out rather than that mistake. It's not a major thing, but dexmethylphenidate is Focalin, whereas methylphenidate is Ritalin. So I apologize for that mistake. And in very young children, one of the barriers, which I think you've probably already gotten the sense from me, is that we know some about short-term risk benefits and untreated problems, and need more understanding of long-term for all of those things. So it's a complex issue, and one that we really want to be thoughtful about. I wanted to also just share a little bit of general information about medications, stuff that I go over with parents a lot, and that I thought might be helpful to you. So, one of the big things is, like, is this a side effect? If you started a medication, or if you're worried about, starting a medication and want to understand about side effects. So in FDA studies, what they do is when they're testing a medication, they have to report any negative event that happens while the person is taking the medication. And so sometimes random events get associated with the medication. So it's only the things, on that long printout that you get from the pharmacy when you pick up a medication, a lot of the things on there are things that may not have been associated with the medicine. The things that pop up at a higher percentage rate are the things that are more likely to be side effects. And the other way of knowing, if you're taking a medication, about whether it's a side effect or not, is really trying to match up the timeline. And, a new side effect or something that's suspected to be a side effect should usually correlate with either a change in the medicine, or the first few days of taking the medicine, or increasing the dose at some point. And side effects are really unlikely to fluctuate dramatically day to day. So if someone has, nausea and vomiting twice a week, but they're taking a medicine every day, it's less likely that it's the medicine. But you still have to investigate it, and they should be talking to their doctor about, anything that they suspect might be a side effect. And the other thing is that, if it's a side effect and you stop the medicine, then it should go away. Another comment, just like if medications are combined, each medicine you add, sometimes there are interactions and sometimes just additive effects where you have more chance of side effects. So we really try to keep medication very streamlined with young kids and with all patients to avoid that. Generic versus brand name. A lot of parents wonder, like, is it okay to use the generic? And I'm not going to go through all the details on here because you could read, but the bottom line is generic is usually just as good and usually way more affordable for the family in terms of the copayment. So we really encourage people to use generics unless there's like a really specific reason not to. All right. Now we, go into the treatment plan. So we've weighed the risks and benefits, had a, conversation with the parents or legal guardian, and really like worked it through. Like, here's what we are going to try. And for young kids, we're generally going to start low with dosing of medication if that's part of the plan. But the curious thing about it is young children, they have really great liver function and kidney function because they're young, their metabolism is high, and they, haven't done some of the things that we as grown-ups sometimes do to our bodies that, make them function less well than they did when we were young. So sometimes they metabolize medicine really rapidly, and we end up putting them on higher doses than you would expect based on their physical size. So I always, go over that with parents because I don't want them to feel scared about these doses. And, we start low, but then we'll, increase until we get to a good effect. So we're rarely going to start at the dose that's going to be the continued dose. I wanted to also mention for those of you who aren't psychiatrists specifically who are on the webinar that there are ways that you can really make sure that medication goes well for kids. So one thing is, ongoing communication. So often, a therapist or prescriber is really interested in hearing feedback from people who are interacting with the kids that they treat. But it can be hard, especially when you're trying to catch a psychiatrist who maybe is at a clinic only a certain number of hours per week and booked up with patients that whole time. That can make communication tough. So these are some tips that I have found have helped me be able to communicate with people sometimes. If there are multiple people on a team working with a family or a child, to pick one designated team member who can gather info from the other sources and maybe streamline that communication. Consider communicating in writing when it's hard to coordinate phone calls. So if you have a, HIPAA-protected platform within your electronic medical record, or, handwritten notes are still something we can do, and really using standardized questionnaires and rating scales, which the psychiatrist may prompt, like, can you fill this out? And that can be really helpful as well. Or can the teacher fill it out or something along those lines? And then supporting parents. So, I think I've been struck over the years, sometimes when I'm talking with patients and they don't realize I'm a psychiatrist, how worried they are sometimes about bringing up what they're worried about to the doctor. So, I think really encouraging them to talk to the doctor honestly, definitely before stopping meds, or if they stopped it already, or if they're thinking about changing doses, because most doctors are going to say, it's your body and you get to decide, or it's your child's body, and let's just go through kind of the pluses and minuses of making that choice so that you're aware and so we can monitor it together. It also can really help for parents to write down questions ahead of time, and they don't always just think of that. So if you suggest that, they may find that very helpful. And then, I as a psychiatrist try to cover this with people, but sometimes in a rush, I don't cover it all. So it can be helpful to have this reinforced, there are lots of difficulties with taking a medication or giving a kid a medication that you have to remember every single day, especially in those mornings when you're trying to get a kid dressed and off to school or something like that. And studies have shown that, only about 30 to 50% of patients with, sorry, I said that backwards. Studies have shown that patients with a psychiatric disorder tend to be non-adherent to their medication about 30 to 50% of the time. And you also may get a tip off if the parent or the teachers or anyone is noticing a lot of day-to-day fluctuation in symptoms. And there's just practical solutions that, again, people might not have thought about, and just a quick, hey, have you tried this, can really make a difference. So pill boxes, putting the medication somewhere that helps them remember. So like if they always brush teeth, then put it near where the toothbrushes are. Of course, you have to be careful with young children to make sure that they're not going to be able to get into medications. So really making sure that there's a good child-safe lid, and if you're going to have it somewhere that the kid might be able to reach it, or just figuring out a place that you'll definitely see it every day, but it's high enough that they can't get to it. Or just something simple like setting an alarm on the phone each day as a reminder. And for some kids, it may work better to have medication administered at school or daycare, although not all places have a nurse available to do that. So, that's something you just have to kind of think through. With young kids, we also run into the issue that a lot of them can't swallow pills. That does limit our options in terms of what medications we can use, but fortunately, quite a few of the things that I'm going to go over with you are available in a liquid option or a chewable tablet, or even some of them, a very few of them, but where you can put a patch on the skin that needs to be changed periodically. But delivers the medication through the skin. Those are tricky in young kids, though, because sometimes they don't like the way it feels, so they're likely to pull it off if they can get to it themselves, or they just fall off because, they're moving around so much, and, anything that's stuck to the skin is only going to stay on for so long if you're moving around a lot. And then I mentioned already how important it is to have a plan for reevaluating medication if we have decided to go down that path. So when we're starting meds, really identifying some specific target symptoms that we can monitor to know if the medicine's helping, having a timeline to reevaluate if it's still helping, and have an idea about, like, when are we going to consider trying to go off the medicine to see if, to reevaluate, have symptoms changed, and might we be able to do without this medicine now. So that's kind of the general approach. Just to summarize, a really good assessment is crucial. Medication really should be second line after other interventions are tried first, and hopefully, it's possible for kids to get access to those first line treatments. Non-psychiatrist professionals can really help with assessment and monitoring of treatment, and strategies to support parents are great, encouraging communication, helping them figure out how to remember medication, and having a really clear plan for reevaluation. So with that, we're now going to go into some categories of different medicines that are used in young children, and I'm just going to give you a little bit of details about each of them, like what are they used for, what are some common side effects, and again, I'll go quickly through certain slides, but hopefully you'll get a sense, and then you'll have the slides, you can review them later. The first thing I wanted to mention as far as a category is the great pretenders. So I mentioned before, all treatments can have side effects, aspirin, any medicine you think of. And there are a number of medications that are used for medical issues that can cause social emotional symptoms. And this tends to be particularly common in young children. The brain is developing, and, the way the whole neurologic system is set up is a little more vulnerable to things kind of going in a direction opposite of what you intended. So these are some common examples, like Benadryl, which is, of course, a very common medicine used for allergies, including in young children. Like pediatricians often, prescribe it, but it can cause disinhibition in certain kids. So if you suddenly see a kid behaving more impulsively than they did before, it might be worth checking, like, have they been taking anything outside of the ordinary? Asthma medications are also kind of notorious for causing some behavioral changes, and because the prevalence of asthma is as high as it is in young children, this is a pretty common issue. We just want to rule it out before making any assumptions about symptoms. Okay, so now we're going to move on to stimulants. So stimulants are the medications we use predominantly for ADHD, or attention deficit hyperactivity disorder. We're also going to talk about a couple other categories of medicines for ADHD, so that's why it says other medicines. But I wanted to really quickly make you aware of this study. This is the best study in so many ways that we have about medications in young children. It's like the gold standard, kind of, this is how we ought to have information for all the medicines, then we'd be really happy and feel really more confident about things. But, I think it's good to be aware of this one. So this study, the PAT study, PAT stands for Preschool ADHD Treatment Study. It was funded by the National Institute of Mental Health. So that's reassuring because it wasn't funded by drug companies who might have a motive to like get their medication sold or something like that. It's publicly funded. They looked at kids ages 36 to 65 months of age, and they went through multiple phases of treatment. I'm not going to go through all the phases, but just to hit a couple of highlights, they did a screening and enrollment where they did a careful assessment and really made sure, like, do we believe this is the diagnosis? And then if the kid was diagnosed with ADHD, they would before they moved on to anything else, they would do the parent management training before moving on to medicine. And if a kid's symptoms really improved with that intervention, they did not move on to medication. So that's going back to that principle that we were talking about, trying psychosocial interventions first in young kids. After that, they were treated with methylphenidate, which has a variety of different names out on the market, but the thing people have usually heard of is Ritalin. And they, did careful dosing and titration and tried to really, maximize effect. And I'm just going to go to the next slide and kind of give you the summary points. So one of the really important things that was established by the study, even though it wasn't necessarily the goal of the study, was that ADHD could be effectively diagnosed in preschool children. Part of the reason we know that is because they followed up with these kids as they've gotten older. And ADHD is the type of thing that, you shouldn't see it resolve in a year. For some kids, they will outgrow it as they get to their teenage years or to adulthood. Some people will continue to have symptoms, so it's kind of a third will resolve entirely. A third of people will have some symptoms, but it won't be as bad as it was, and about a third of people will continue to have significant impairment with their ADHD symptoms even into adulthood. But, between age 3 and age 9, you wouldn't expect, that many of them to have resolved their symptoms. And what they found, which you see just above on this slide at the 6-year follow-up, is that 89% of the kids who had been diagnosed with ADHD still met the criteria for ADHD. And that was at age 3 or 4. So it was very reassuring that we could effectively diagnose and be correct in the diagnosis. If we were careful about how we did it. And then another big thing they noticed that there were differences in side effects compared to older children, with younger children being a little more susceptible to certain side effects. But they also saw improvements in ADHD symptoms and associated functional outcomes. Not quite as robust as in an older kid. So what I always talk with parents about with this is that, if we think that ADHD is the right diagnosis, and we decide that medication would be an appropriate thing to try, that we'll try it now, and we'll see if it works. We'll see if there's side effects or if there's intolerable side effects, and we'll see if there's improvement. And if we don't see the right outcome, that we'll stop the medicine. But that doesn't mean that, you shouldn't reconsider it as your child gets a little older. I'll give a case in point. There's a child that I'm seeing now. I first saw the child when he was 3, and his parents were worried because he was very hyperactive and was really struggling in his preschool program. They didn't want to start medication back at age 3, and were very on top of trying to do all the other types of interventions possible, and really worked very closely with his school. And he managed to make it till around age 6, when things just weren't as the expectations for, being able to sit in class and behave for longer stretches of time escalated as he got into first grade and second grade. It became harder for him to manage. So now he is taking a stimulant. If he had tried it at age 3, we might not have found that it worked as well, but at age 6, it can work very well. All right, I'm not going to go into a lot of detail on this, but I just wanted to give you a sense of why do these medicines do anything? So in our brains, and this diagram this picture on the slide is kind of a diagram of some neurons, so some brain cells, and the blue ones are the nerve cells that are sending a signal to the next neuron, which is in green at the bottom of the slide, or at the bottom of the picture. And you see all this stuff floating around in here, and these things on the surfaces of these cells that are receptors for neurotransmitters, and the neurotransmitters are the stuff that's floating between. Two really important neurotransmitters for mental health are dopamine and norepinephrine. And these medicines that are called stimulants, which are really methylphenidate and amphetamine, impact on the dopamine and norepinephrine systems in the brains. And, in different parts of the brain, that these neurotransmitters do things like help with concentration, attention, hyperactivity. They also have some role in depressive symptoms, fatigue, and sleepiness. So they really do a lot of different things. And so what we do with the medicine is we try to, help with stuff like concentration or hyperactivity if that's what the person is struggling with. And that's what our target symptoms would be. The thing about the stimulants is really interesting is there's really only two kinds. There's methylphenidate and there's amphetamine. But then there are a whole bunch of different versions of each of those. So I put here on the slide a picture that says ADHD medication guide. This is the front of a handout that is updated periodically, and it's the back side is also covered with lots of different pills, showing you what all the different ones look like. And it's only the brand name ones that are on here. So the generics look there's even more options for how the pills might look. But it also goes over the things like which ones come as a chewable or a liquid or a patch, so that we can really look at the different options for kids. Another important thing to know about stimulants is that there's short-acting ones, which usually only last about 2 to 4 hours in terms of symptom addressing symptoms, and then longer-acting ones, which have varying lengths of action, somewhere between 8 and 12 hours. And so sometimes as we start a child, whatever age the child is on a stimulant medication, there's some figuring out which one between the methylphenidates and amphetamines works best for this kid, and which version of each of those, may be best for this kid. So there's sometimes, a degree of not experimentation exactly, but educated adjustments to the medication until we get it just right, hopefully. And sometimes we might even be combining some longer acting and shorter acting meds to make it work the best for the kid. Take home points about stimulants. And again, this is the medicine that I would think you might see the most often. So that's why I really wanted to spend a bit more time on it. But there are really only two types, methylphenidate and amphetamine, but there's a lot of different brand names that those go under. The delivery of the medicine varies by which formulation, and so we're often trying to figure out what works best for this kid. About 50% of the time I can get it right the very first time by, taking the symptoms and everything very carefully and thinking about what's probably going to work best for this kid. But then there are also lots of times where I'm adjusting doses or even changing medication to try a different one before finding the absolute best plan. This slide I'm going to summarize really quickly. I had told you before with medicines to start low and go slow, but with ADHD, there's been a lot of evidence that unfortunately kids get started on a low dose and then no one increases it, and so they're getting exposed to a medicine and it may be at a dose that's not even really helping them. So, with stimulants, you can see a pretty immediate effect. It's helpful to average a few days, but, really you don't need to wait a month or a couple of months before deciding if this is the right dose. You can adjust it more quickly. It can help to have standardized rating scales. I put a picture of one in the top corner there. And so, that you'll often see that psychiatrists are trying to get somebody to fill these out, so to try to get a little more objective idea of how's the kid doing at school and how's the kid doing at home. The other thing I'll mention, because this happens pretty commonly, is a lot of parents like to, with stimulants, to take their kids off the medicine when there are opportunities, so when they're on holiday from school, and that's something that we discuss with parents and try to work through. In the interest of time, I'm not going to go through every side effect possible. Suffice it to say there are side effects that can happen. Some are really common. Some of them tend to go away, like after a few days, and some, you have like strategies that you can kind of work around the side effects. There's a few that we worry about more, so we talk about parents with those ahead of time. One of the ones people worry about with stimulants sometimes is cardiac side effects, so something with the heart. It's really, really rare, and generally it's been always found to be associated with a pre-existing cardiac problem. So we have a series of questions that we ask parents and kids before starting this type of medicine, which helps screen out anybody who might have one of these underlying problems. If the answer to any of those questions is yes, then we'll generally be sending the kid to their pediatrician or maybe even to a cardiologist to get things checked out before starting medicine. Another thing you might see sometimes or hear parents talk about is rebound. This is like kind of as the medication is wearing off, when there's an increase of symptoms, sometimes even above the baseline hyperactivity and impulsivity late in the day. And there are strategies to work on that, but it's not super common, but for the kids where that's a thing, it can be quite noticeable. So, if you've heard about that from a parent and they haven't talked with their psychiatrist about it yet, make sure and encourage them to do so. Stimulants, and so going on to other medications for ADHD, it's pretty common to see younger kids on medicines, these two medicines, clonidine and guanfacine. I've included the brand names here as well. There's also another brand name for guanfacine, Intuniv, which is a longer acting version of that same medicine. And these are old blood pressure medications, but they work by affecting a receptor in the brain, just like those dopamine and norepinephrine ones that I was talking about before. So they're actually useful for some mental health symptoms in addition to being useful for blood pressure. So we borrow from that category of medicines, and these are not really so much helpful with inattentive symptoms, but can be really useful for hyperactivity and impulsivity, and for some other problems like PTSD, emotional dysregulation, irritability, and sleep problems. So, and they're quite benign in terms of side effect profile. We do have to go slow with them because we don't want kids' blood pressure to drop. But, if we do that carefully, they're otherwise quite well tolerated. The only side effect that sometimes comes up that might otherwise limit use of these is if kids get too sleepy on them during the day. But so we use these quite a lot just because they really don't have a lot of side effects, are very well tolerated, and can be helpful with a number of different symptoms. And the last medicine I'll talk with you about for ADHD is atomoxetine, also known as Strattera. So remember I said dopamine and norepinephrine were the targets for helping with ADHD symptoms, and this also works for norepinephrine. It's had a recent study showing effectiveness in preschool age kids, so that's why I include it here, but it's much less commonly used than the things that I already covered, but you might run across it. I think I've mentioned everything about, everything that's on this slide. Maybe I didn't say specifically that dextroamphetamine is the one that's FDA approved, but I told, as I was mentioning to you before, the best study used methylphenidate. So it's actually usually the go-to as a first medicine for young kids. All right. Switching gears, I'm going to quickly tell you about antipsychotics. So antipsychotics treat psychosis, which is a collection of symptoms, including hallucinations, delusions, problems with thinking clearly. And, those symptoms are incredibly rare in young kids. And if they do have them, it's sometimes difficult to tell if they're, using their imagination versus actually having those symptoms. But if they do, it's often because of a medical issue that's going on. It's not because they're diagnosed with a psychotic disorder. That's something that really, comes about in the teenage and adult years, and is extremely rare in young children. So, why would we ever use these medicines in young children? Because they don't usually have the disorder for which they are the primary treatment. The reason is because these medicines work, again, on dopamine, as we talked about for the stimulants, although they work in the opposite direction. They decrease dopamine a bit in the brain, or decrease the impact of dopamine, but they also work on other receptors and neurotransmitters, and so that gives in part, side effects, but also means that sometimes they're useful for treatment of other issues besides psychosis. And they're overall used at pretty low rates, but there has been some concern that the rate has increased in preschoolers. So this is that study that I mentioned I'd come back to. In this study, they were kind of worried about the amount of antipsychotics that were being prescribed to young kids, and specifically were worried that those kids hadn't had adequate mental health assessments or gotten psychotherapy and seen a psychiatrist specifically. So that is concerning because, as I'll show you, these medicines have a lot of potential side effects. Just for your information, this is a list of a bunch of different antipsychotic medicines. So if you hear of one, you can recognize that it's this type of medicine. And this is the FDA approvals for antipsychotics in children and adolescents. And one thing that you'll notice here is that most of them are only for age 10 and up. So you do see for autism and that there's some indication for use in 5- and 6-year-olds for irritability and autism. But at the bottom of the slide, and I'm sorry that's cut off a little bit, but they're also commonly used for other things besides what the FDA label says. So impulsive aggression, mood lability or irritability, augmentation of antidepressants, etc. So you may see them used in young kids. There's a limited amount of evidence to support use in preschoolers for autism. And it's really, again, to treat irritability in autism. It doesn't treat the core symptoms of autism, like the restricted interests and the repetitive behaviors and the poor social communication skills. But for those kids with autism who have a lot of irritability and that's really impairing their functioning, it may help with them. They're sometimes used for ADHD and disruptive behavior disorders, but there's not really good evidence for that. So this should not be the first thing that people go to with with those types of problems. And this is a list of side effects. I told you it was a lot of them, and some of them are, concerning in ways that are not just nuisances. So really, we want to try to steer away from using these medications whenever possible in young kids and in kids and adolescents in general. So here's a little summary kind of going over some of what I just mentioned. In the interest of time, I'm going to move on. So just to go over a couple other medications you might see used in young kids, antidepressants are sometimes used, but there's really very little evidence for use in any kids under age 6, which I'm showing you here again, like the FDA indications for antidepressants in kids, and you'll see there's nothing that goes down below age 6. There are some case reports, and based on that, for young kids, the most evidence is probably for fluoxetine and sertraline. At the top, I gave the most evidence for children and adolescents in general, and that includes Lexapro. But for young kids, it's really those two, fluoxetine and sertraline, and really used for treatment of anxiety disorders in general, and not so much for depression in preschool age kids. This is a little summary of common side effects for SSRIs, which are the medications I was just telling you about. And then, again, just a little summary. So we might use these for anxiety disorders when they're quite impairing, and it really needs to be in combination with therapy. There may be a little evidence for efficacy in autism, but it's very limited research. And, then there's some older medicines that used to be used for enuresis that are in the antidepressant category, but there are other interventions that are usually better and preferred now. We don't really use mood stabilizers in young kids, although occasionally I run across a young kid who's been given a mood stabilizer from somewhere else. Mood stabilizers are traditionally used for bipolar disorder, which very much like psychosis is incredibly rare if it even exists in the preschool age group. So if mood stabilizers are used in young kids, it would generally not be for that traditional use. Now, like all the medicines I've been telling you about, they can be useful for more than one thing. The medicines that fit into this category are lithium, which is in a category all of its own, and then a lot of anti-seizure medicines. So valproic acid and lamotrigine are two examples. And the one thing I'll mention here is, first of all, if you see a kid on one of these medicines and the parent, expresses concern, definitely encourage them to ask more questions about, what's going on? Why is this the medicine for my kid? And then also be aware that if you see kids who have seizure disorders, they may be on some of these medicines since we're borrowing them, and they may have higher risk for mental health issues. I mentioned Benadryl earlier. We use that sometimes, but we have to be careful about that paradoxical reaction where you can see disinhibition for kids with antihistamines, but we sometimes use it to help for, sleep or just for a calming effect in kids, including young children, if they're really struggling. And on that note, I wanted to just mention sleep. The first thing, again, going back to that idea that a careful assessment is the most important thing, that psychosocial interventions like good sleep hygiene should be the next step. And then there are some medicines that we use for insomnia. So I listed here clonidine and Benadryl, which we've talked about already. And then melatonin, which is a hormone naturally occurring, seems to work pretty well in young kids for certain ones who really have a sleep problem that's not resolved by these other interventions. So with that, I've taken you through a very quick tour of lots of stuff, and I'd like to open it up for any questions, comments, or discussion you might like to bring up.
Well, thank you so much, Rebecca. This has been a really incredibly informative webinar. We do have several questions that people chatted in, and I'm going to combine two questions here. One of them is, do you recommend parents take data on specific behaviors to see if the medication is effective? And another question, how are you helping parents identify the symptoms, behaviors in a way that they can objectively provide information to you and you can determine the effectiveness of the medication?
Those are great questions. I touched on a little bit, although I didn't make it the focus of the talk, that using standardized rating scales can be super helpful for both of those things, because, it can help to, go over certain things with parents, like let's track this and this, but having like some specific questions that, they'll answer once a week or something on a rating scale just helps objectify it a lot. I don't want parents to try to track so much stuff that it becomes a job of its own. It shouldn't feel like that, but it's really important to have some specific goals that you're going to be tracking to know if things are effective. So I'm very glad that you brought up that point. And I think, if for those on the webinar who are therapists, they can have an active role in working with the psychiatrist and helping the parents track these things. And they themselves may be able to track certain symptoms because they may be seeing the child more frequently than the psychiatrist will be able to do.
Very helpful. So one last question, and then we'll end. Where was the PATH study done, and what was the name of the parent training?
Okay, so the PATH study was done across multiple sites in different parts of the country, so different academic institutions combined forces, and which is good because then you get a variety of different settings and different clinicians, and you can kind of just make sure, like, is this working kind of wherever we try to do it. The name of the parent management training in that study was, it was essentially something they developed for that study, but it has like the same principles in it as most parent management training programs. So one that I really like, just because it's very simple to implement, is the parent management training modules from the MAP program. That's something we could send out a little information for people if that would be of interest as part of the follow-up to the webinar.
Terrific. Well, I'm going to do one more question. We're getting a few other questions, and if people want to type them into the TTAC info email, we will certainly make sure that we respond to all of them. There's been so much information. But last question is, which rating scales are good for kids 3 to 5?
Yeah, that's a great question, and the answer is not a whole lot of them. So I won't give you a comprehensive list. There are a few that are good for like kind of a global assessment of symptoms. So really commonly used are the child behavior checklist, which you can use starting at age 1.5. ITSY or the BITSY, which go down to age 0, but only go up to age 3. So it's a bit of a hodgepodge. And then there is a preschool ADHD symptom checklist and a preschool anxiety checklist that are both pretty good. So I could share the names of those if that would be helpful.
Well, this has been enormously helpful. Thank you so much. And again, there's 1 or 2 other questions. Please feel free to text them into us, and we will respond to you. But thank you so much, Dr. Weis. This was just terrific, and it's been a very informative webinar. So thanks for joining us, and I hope everyone will stay tuned for upcoming webinars as well. Thank you.
Thank you all.